8, 2012. Government service was a culmination of a career path which previously spanned industry and the academe. The task of leading the FDA has been the most challenging aspect of her career and also the most fulfilling. Our speaker earned her Bachelor in Science degree from UP Diliman and her medical degree from the University of the East at Ramon Magsaysay Memorial Medical Center. In 2007, her alma mater honored her with an Outstanding Alumna in Leadership Award. She has published papers in scientific journals and has given lectures on pharmacovigilance and various topics in pharmacology, among others. This year, the Philippine College of Physicians presented her with a presidential award in line with the work on labeling, which is intended to help consumers choose healthful foods in line with the DOH strategy to combat non-communicable diseases. Before joining the FDA, our speaker had worked with industry and then joined the Department of Pharmacology and Toxicology of the UP College of Medicine as professorial lecturer. As FDA head, she had to address a wide variety of issues ranging from nuclear fallout during the Fukushima crisis to food contamination issues involving plasticizers, and in addition, counterfeit and adulterated products, as well as toys and unsafe cosmetics. She pushed for the ISO certification of the FDA, mandatory GMP and inspection of foreign drug sources, expansion of the bioequivalence requirement, and strengthening of pesticide regulation, aimed at developing a proactive regulatory body that can effectively prevent disasters. Ladies and gentlemen, to give the keynote address on the public health impact of vaccines, addressing the challenges in areas of limited resources, a warm round of applause for our speaker, Dr. Suzette H. Lazo.
I'd like to express my gratitude to the organizers and the officers of PFV for this singular honor. I probably was chosen because I had a rather extended internship in the DOH. So it's an honor to fill in for the DOH's Secretary of Health and also other colleagues like Dr. Eric Tayag and Dr. Irma Asuncion. So I will do my best. It's also a very wonderful opportunity to probably speak my mind, knowing that having gone through the internship I have mentioned, I was in a position to really immerse myself in situations associated with the workings of the Department of Health in its trying to fulfill its mandate to protect public health. And so with that understanding, I could probably synthesize certain perspectives and try to put in with some things that hopefully will help certain issues. My topic, for instance, today is the challenge, the impact of vaccines on public health, and the challenge in addressing issues in areas of limited resources, of which the Philippines falls into being one of the lower and middle income countries in the developing world. We have to remember that since the time of Jenner, we've come a long way. The word vaccine, taken from vaca, which was the source of the cowpox. And to the present, when Dr. May already mentioned the eradication of diseases like smallpox, polio, and soon measles, and we're also stepping on the boundaries of cancer control and prevention. So it's going to be an exciting time, and undoubtedly, vaccines is one of the most important achievement in the area of public health. The graphs and the charts which abound show the very spectacular fall, for instance, in incidence of disease, approaching 100%. Of course, we still have to contend with diseases like pertussis, meningococcemia, but undoubtedly, again, vaccines really work. So as far as efficacy and safety is concerned, I'm sure we all believe that, that really is with the highest scientific evidence. That's why we are here today. In light of this, that the Philippines, through its efforts in the DOH, and I know how hard it is to be in government to balance the limited resources with the processes involved, for instance, in procurement. And you have much ground to cover. Sometimes the work really extends on a 24/7 basis. The achievements of the Department of Health in bringing about success in immunization is really rather low profile. And sometimes I think, they do need a little more recognition, because the people, and some of them are here, my dear colleagues, Dr. Joyce, and also Engineer Anna, these people who have been working for years are really irreplaceable. And so if we can give them a pat in the back and give them an applause for all the efforts through the years, I hope they will consider staying on forever and do their work, because the country really needs it very badly. Now, given this situation in the Philippines, we have several issues that range from sourcing, for instance, manufacturing issues, distribution issues, and the rise of certain activities like counterfeiting has not spared vaccines. And also on the ground, especially when we are already administering vaccines to patients, there are safety issues that arise. The National AEFI Committee, for instance, meets regularly to look at this very rare but very alarming incidents involving serious AEFIs, and even with some patients dying. So we're also struggling with trying to put in some causality assessment. If a baby dies following DTP infection, you can imagine the wave of anxiety and the controversy that suddenly erupts. Is it because of the vaccine? Or is it because of an underlying issue that, coincidentally just happens to be happening at the same time as the interval following a vaccine? So these are the questions that we need to answer. We also have other more practical considerations, like issues of pricing. The pricing of vaccines is a very complicated issue. And there are differential pricing as well. And global activities through the Gates Foundation, for instance, have also made innovations in trying to address pricing. So, there are other issues as well, aside from safety. The shift of sourcing compared to maybe 10 years ago, when all the vaccines were sourced mainly from the US. That means the manufacturing happens in the developed countries. In recent times, for many drugs, including vaccines, the source has become other countries within the sphere of our region. So what differences in manufacturing has come about because of this? Also, the public health needs of developed countries differ from ours. Just look at pertussis. They have abandoned the use of wholesale pertussis vaccine, which we still use. They also don't have typhoid fever very much, but we do, so we need a vaccine. Cholera vaccines, and other countries need Japanese bee encephalitis vaccine, yellow fever vaccine. The Philippines has a problem now with dengue, and so it's with great anticipation that we wait for the successful deliverance of probably something that we could use. So the mix is different. And whereas before, many of the signals, the safety signals that we gather emanate from these countries, now we suddenly find ourselves on the front line. We have to be able to detect the signals. To detect signals that may come from variations in manufacturing, for instance, and also because of the differences in the type of vaccines that we use. So the need to really come together and establish a stronger workforce that can work on a more reliable and scientifically based signal detection, investigation, and causality assessment. So these are the things that we now see in front of us. But let us not consider ourselves alone. We belong to the global community, whereby there are helping hands ready to link with us. On top of this is the World Health Organization that has declared 2012 to 2020, the decade of the vaccines. They have initiated the Global Vaccine Safety Initiative, and with it the blueprint. So it's there for us to link up with, because the objective of WHO is to help countries set up an adequate system whereby there is also an adequate pharmacovigilance capability to be able to detect these signals. Because that's one way whereby you can also avoid getting into further trouble. You know, the success of the vaccines in a way has worked against it. Over the years, as the incidence of diseases like measles, mumps, etc., have gone down, the perception have become that they are no longer health problems. In that sense, you know, what do you need the vaccines for? And the perception also becomes more rigid in terms of the risk. People almost expect vaccines to be 100% safe, which is not at all possible. So you have the rise of anti-vaccine groups already mentioned by Lulu, and they are all over the world. They have websites that include misleading information. And in this regard, the WHO, if you look at the website of the WHO, because they have reviewed all the sites and they've come up with criteria to say that a certain website, for instance, is reliable. They do have a list of reliable websites on vaccine information. So we are in this age of information, and I hope we are making use of this. There are also publications that are ours for the taking and to use. For this year, the WHO SEOMs have published the standardized definitions for vaccine-related issues such as AEFIs. And this already endorses the Brighton collaboration definitions that has been forthcoming for, I think, the past decade. So this standardization is important because when we make our own causality assessment, we will base our diagnosis, for instance, on those definitions. And so when we talk with other countries abroad, we will be talking about the same diagnosis using the same criteria. There are other things in the global community that we can use. That's why I think we have to think global and not just confine ourselves to our problems. The current internet really makes this very possible. The information flow is there already. We should look at models in other countries. In the US, for instance, the spontaneous reporting system, VAERS, VAERS, has been there for a number of years and it works. So with the UK yellow card system. But of course, the Philippines also has some reporting on adverse reactions, but our current reporting is geared towards drugs. That's why we need, for instance, to make a separate form for the vaccine reporting that should contain the necessary information we need. We should also look at the Uppsala Monitoring Center, which is the database for all the adverse drug events, including vaccine, that has been collected. And you can do this within the day, so it's quite easy. Going back to the US, because spontaneous reporting or the passive surveillance does have its limitations. We should try to study also the models that they have. There's the thing called the VCD data link, which is a linkage between the FDA and the 8 biggest HMOs. Because all the data is there, then it's easy to test hypotheses, for instance, and look at the actual causality. There are other countries that have very well-developed systems to monitor vaccines, and I think we should open our eyes to these models and try to adapt what is workable in our situation. So, while we really should not follow in toto perhaps what they do, we should find that sustainable setting whereby we can create our own system, but still do the essential things. Regulatory, for instance, now faces so many things it has to address. The regulation, for instance, of influenza vaccine is different from the regulation of other vaccines. Why? Because as you know, influenza vaccines are changed. The strains are changed every year. So how can the PMS work when our PMS now requires a 3-year, drug surveillance? We have to modify that. We're also going into biotech industries, and of course, as you know, vaccines are biological products. But this is where regulation is now trying to also work. So I think we have the chance to really make the vaccine work even better. We are very lucky because I think overall the public has a very positive perception of the vaccine. And I think we should not take that for granted. I really support the proposal Dr. May has been saying that, education and communication is very important because you need to educate the parents, you need to educate the public, and you also need to educate the media. So it has to be taking all the whole issues in total and trying our best to address it. At the same time, trying to adopt the highest level of scientific know-how, because we already have the people and the capability here to do the causality assessment. There are many sources that I want to share with you. The Institutes of Medicine, which is an institution tasked by the US Congress to look into the scientific issues it has to deal with, has a publication arm. It's called the National Academies Press. And for the certain countries, the Philippines included, you can download books from that site. And only this year, there was a publication that came out on the adverse effects of vaccines, evidence and causality. And that is the gold standard for looking at relationships, for instance, between MMR and autism, the safety of thiomersal in multi-dose measles, and many other issues like Guillain-Barré syndrome and influenza vaccine. So I would urge you to visit that site and download as many as you can, because it's free and it's there for the taking. So the best knowledge are there for us. You don't have to subscribe. It's free. New England Journal of Medicine also has many articles that give free information in PDF form. So in that, with that note, I think I will now end here. And of course, I hope you will enjoy the course. There's a lot to be learned, and always looking forward to newer, better vaccines, safer vaccines, and really trying to prevent disease, which I think you being here are really complying with the essence of your profession, that's sworn to protect human life and really, really save patients from dying. Thank you very much.
Another warm round of applause for Dr. Suzette Lazo for putting in a nutshell the challenges that we face in achieving our confidence in the public health impact of vaccines. So, speaker completed her Doctor of Medicine degree at the University of the Philippines in Manila and had her residency in pediatrics at the UP-PGH. She finished her research and clinical fellowship in pediatric infectious diseases at the Department of Pediatrics of UP-PGH and obtained a diploma in vaccinology at the University of Paris and Institut Pasteur in infectious disease in 2009. She is a medical specialist 3 at the Research Institute for Tropical Medicine, where she is the training officer for pediatrics and the chair of the Infection Control Committee. She is a member of the National Immunization Committee of the Department of Health in 2010 and a member of the 18th Technical Advisory Group on Immunization of the Western Pacific region of the WHO for 2009. She is also a member of the Technical Working Group of the Department of Health on emerging infections, meningococcal infections, HIV/AIDS, and hospital infection control. She has completed numerous researches and publications, mainly on vaccines, and is a contributing author to several books and clinical practice guidelines on various topics in infectious diseases. Ladies and gentlemen, to speak on do's and don'ts of vaccination, please welcome Dr. Charissa Faye Corazon Tabora.
Good morning. Since it's really very difficult to see my lecture from here, I decided to walk, so it's easy for me to. Is the pragmatic part of the three speakers' lecture that I following them. So this will put into practice what Dr. Bravo, Dr. Montellano, and Dr. Relazo have said on vaccines. And basically, it will put into practice the principles of vaccination. Hopefully, this will help you deal with everyday questions as clinic managers, as vaccine advocates, as doctors in your daily practice. So when they said, do's and don'ts of vaccination, I asked, which part of vaccination? And they said, a little of everything. So indeed, this morning's lecture is a little of everything on the do's and don'ts of vaccination. First, do no harm. We all know that as physicians, and this is part of our Hippocratic oath. So for today's lecture, I decided to still separate them into three. We start with vaccine storage, the do's and don'ts, followed by vaccine administration, the do's and don'ts, and then lastly, general recommendations. So we start with vaccine storage. First, do provide reminders. Make sure that your vaccine refs have reminders. Do arrange vaccine by age group. Do keep vaccines in their original boxes. And do use refrigerated or frozen gel packs. Do not use loose or bagged ice. I always see a lot of vaccine managers coming to us and asking for vaccines or buying vaccines, and they put them in loose or bagged ice, okay? So make sure your vaccine ref has this reminder. And I think you also have, because now with the growing number of vaccines for adults, to arrange vaccine by age group, lest you inadvertently give hepatitis A or some flu vaccine preparations to adults instead of children or vice versa. Next. Do monitor vaccine refrigerator temperature twice daily. So this is an example for a vaccine ref at the pharmacy of RITM. And you see this paper here shows the temperature monitoring sheet, which is done by the staff 2 times a day. And do maintain vaccine storage temperature between 2 to 8 degrees. Most of the vaccines that are available in our country are stored best at 2 to 8 degrees. So that's just what you have to remember. Other countries do need sub-zero refrigerator freezers, but for practical purposes, in the Philippines, you won't go wrong if you store them at 2 to 8 degrees. Do not store food in the vaccine refrigerator. Do not store vaccine on shelves on refrigerator doors. So this is an example of a vaccine refrigerator. Look, it even has a number there that's filled with food. Please ask your secretaries, especially in private practice, who also sell soft drinks or who also sell water, to please buy them another ref, okay? Because even our secretary in Manila Doctors is guilty of that. So that's why we have 2 vaccine refs in our clinics. Okay, do not place a do not unplug sign near the outlet of a refrigerator. Look at this, it says, do not unplug refrigerator or break circuit. And if you look at this, there's a small, this is too close to see, but this is now the telephone number of our nurse in charge of vaccine storage in case there's power outage problem, because you have to call them. It's important to do this because a few years back at the old medical city, Dr. Sally Kitchalian and I lost about 40 to 50,000 worth of vaccines because on a Saturday, the janitor felt that he was doing a good deed to us by unplugging the ref and cleaning the ref. And when we came in on a Tuesday, because our clinic was a Tuesday and a Thursday, lo and behold, all vaccines were at room temperature. So you could imagine our loss at that time. And it's really very important that you put this at the outlet, at the plug of your refrigerators. Okay, power outages. Do transfer to alternative storage with a reliable power source. So your clinic should always have a backup plan. If there's an ondoy or a sendong, what will I do with my vaccines? And that is the reason why some of those doctors who do not have a very good backup plan do not store so much because they're scared that in case this happens, they will really have to transport vaccines out of sight and have to maintain it at the same time at 2 to 8 degrees centigrade. Do label exposed vaccine and separate from new stock. Do not open refrigerators until power is restored. There's a different altogether lecture on vaccine storage and cold chain management, but this is an example of a vaccine that has had some power fluctuations with the refrigerator, and what we put is, do not use, these are quarantine vaccines. So meaning to say, if you cannot dispose them at that time, put a sign saying you should not be using these vaccines because they were exposed to fluctuations in temperatures. Okay, so that's basically for vaccine storage, and we hope that although it is not encouraged that you use household refrigerators, we know that the cost of a commercial biological refrigerator prevents most clinics from purchasing one. We go now to vaccine administration. Number 1 rule, do use only vaccine diluents provided by the manufacturer. So please remember this, because I've seen a lot of nurses and doctors who would buy the normal saline when they lose their the diluents. So they come together, and it is because of this that you should not be separating your diluents from your vaccine. Okay? You only have to use vaccine diluents provided by the manufacturer. Do clean the rubber stopper on the vaccine vial. It is not sterile and should be cleaned with a sterile alcohol pad after the cap is removed. So you see, after you remove the cap, do not assume that that is sterile. It is not. So make it a habit to clean the rubber stopper. Do not open more than one multi-dose vial at a time. This is especially for vaccine managers at local health centers. Even if you anticipate that there are 20 or 30 mothers who are coming today for their tetanus shot, you only have to open one vial at a time. Do not refill syringe with vaccines that are supplied in vials. So I know that it is a habit of some centers to aspirate all and refill the syringe, put them now on a tray, and bring them outside and start giving them. So do not do this, because if you will be doing this, and there's also another program ongoing, the risk of mixing the different syringes is there. And you do not even know what you're giving now. If it's insulin, if there's also another clinic ongoing in that clinic, or if it's the vaccine. Because remember, they all look sometimes the same, and I'm sure you will not take pains to label them. It is not necessary to change the needle after withdrawing a vaccine from the vial and before administering it to the patient. This increases the risk of sharps, injury, and bacterial contamination. We're speaking now of your single-use and single-dose vial. It is not necessary to change. If you aspirate it, you just give it immediately because you're going to discard everything anyway, and you're not going to use the needle with any other, because this is a single-use. We know that the DOH supports a single-use policy. Next, gloves are not routine. So remember this. Do wear gloves if contact with body fluid is anticipated or vaccinator has open lesions in the hands. Otherwise, you may opt not to wear gloves while giving immunization. Next. Do swab the injection site with alcohol and allow this to dry. This is basic. Okay. Aspirating back on the syringe before injection is not necessary. There are no large vessels in the anatomic areas that are recommended. If you know your anatomic areas, which is your vastus lateralis, for infants and toddlers, and your deltoids for child and adult, then we know that at those sites there are no large vessels. And it is not necessary to aspirate as we were taught in med school. This is for other injection sites, not for vaccine sites that have been identified. The British call it a jab, and the best way to give it is a rapid plunge and a rapid withdrawal. Do it quick, do it fast. Okay? Do give it fast but sure. Next, do give multiple vaccines in the same limb, but they should be separated by 1 to 2 inches. We know that there are times when we try to catch up. We have this usually in private practice when they're leaving the country, and the country they're getting into requires so many immunizations, and we only have so much time to give them. So we can give multiple vaccinations in the same limb, but we have to give them 1 to 2 inches apart. Next, do not count any dose given, mishandled, or expired. Okay? Do not count mishandled or one that has been exposed to various temperatures which we do not know, or a vaccine that is expired, that dose is not counted. And finally, do dispose all materials using medical waste disposal procedures. Be sharp safe. If your hospital or your clinic cannot afford to buy sharps container like this, although we know that they're down now to like 50 to 60 pesos for the bigger ones and 25 pesos for the smaller ones, then you try to improvise by using the old plastic gallons that we have for soy sauce and vinegars. And then hopefully we're able to dispose them properly through hospital waste management, third-party providers. Okay, next we go to general recommendations. General recommendations now will go through the different frequently asked questions that we encounter in our day-to-day practice as vaccine advocates. Okay, any vaccine can be given at the same time. Exception, varicella and smallpox. And because we don't give smallpox, that exception for today should not be counted. And MCV and PCV, this is your meningococcal conjugate vaccine and your pneumococcal conjugate vaccine in anatomically or functionally asplenic children only. So, if you do not, so basically, you can give any vaccine at the same time. Okay. You can give any vaccine in any time sequence. Okay? Different inactivated vaccines together, or live and inactivated vaccines together. So it's the same exemption. It's your MCV4 and your PCV in anatomically or functionally asplenic children. But in the normal population, you can give. Next, live vaccines not given on the same day should be given greater or equal to 28 days apart. Exemption, your yellow fever vaccine, which you can give anytime. Live oral vaccines, like your rotavirus vaccines, your typhoid vaccines, and adenovirus vaccines may be given at any time in relation to any other live vaccines. There is no maximum number of vaccinations that can be given in a single day. In private practice, your only limiting factor will be the cost. In government, it will also be the cost. Because to give all those vaccines in a single day, you would need logistics. There are minimum acceptable intervals between doses of the same vaccines. Okay? Exceptions. The 4-day grace period for the inactivated vaccine. Meaning, if the minimum interval is 28 days and you gave it at least 4 days, within 4 days less, which is like 24 days, then that's acceptable. Or early accelerated or compressed schedules in certain situations. So these are when there are epidemics, pandemics, or outbreaks. Okay. A minimum interval is a minimum interval. And that is the reason why we're trying to explain this to you. Please try to be on track or on schedule. A minimum interval is a minimum interval except when it is not. So when is it not a minimum interval? Or what are the acceptable situations when this may be allowed or we count the dose as valid? First, the minimum interval between dose 3 and 4 of your DTaP is 6 months. However, if dose 4 is given greater or equal to 4 months after dose 3, the dose is considered valid. This is one. Next, for less than 13 years of age, the minimum interval between doses of varicella vaccine is 12 weeks. However, if the second dose has been given greater or equal to 28 days after the first, it is considered valid, except in immunocompromised individuals where doses less than 12 weeks apart are considered invalid. And third exemption, the dose 3 of your HPV should be given greater or equal to 24 weeks after dose 1. But if the interval is greater than 16 weeks, the dose is considered valid. So these are the 3 situations or exceptions to what I have said. Okay. There are minimum ages for administration of all vaccines. There are only 2 exceptions to these. First, hepatitis B, which you can give at birth. And second is your rabies vaccine, which you can give anytime. The rest you have to read. There's a minimum recommendation. Partial or fractional doses of any vaccine should never be used. Exceptions, none. So meaning, if you gave half because you wanted a dose-sparing immunization and wanted to share 1 vial to 2 kids because you're trying to save on cost, then you're doing it the wrong way. Because no matter what you say, this is never going to be counted. A multi-dose series should not be restarted if the recommended dosing interval is exceeded. So if it's more than the interval, you count the series, you count it as part of the series, you do not restart it. What is your exception? Some experts recommend that for oral typhoid 21A, to repeat the series if all 4 doses are not given within 3 weeks. So this is the only exception to that. Okay, similar vaccines made by different manufacturers are interchangeable. Exception, there is a preference. Take note of the word preference for using the same of the following for the entire series. Your DTaP, your rotavirus vaccine, your HPV vaccine, and your pneumococcal conjugate vaccine. We're not saying you should not, but for these vaccines, there is a preference to use the same manufacturer to complete the series. There is no harm vaccinating a person who has already had the disease or the vaccine. Exemptions. Too many pneumococcal polysaccharide or tetanus toxoid or DT can cause increased reactogenicity. So this is more on the timing rather than the, too many doses, because we know that for tetanus toxoid, we really have to give booster doses. And another exception is anthrax vaccine in those who have had anthrax disease. Okay. Live vaccines should be deferred after receipt of antibody-containing products. Exceptions, your yellow fever, oral typhoid 21, your live attenuated influenza vaccine, but you don't have them locally, your RB vaccine or rotavirus, we also don't have the adenovirus and the zoster vaccine. So MMR and varicella should not be deferred in postpartum women who receive antibody-containing products during pregnancy, including your anti-RHOD globulin. So, any immunoglobulin-containing vaccine products received in pregnancy are not counted and should not deter you from giving your MMR and varicella to women of age-bearing potentials. Okay. The reason I put this slide is because we always have mass immunizations. And getting your measles through your tigdas or knockout tigdas or your SIA or supplemental immunization activities does not mean that it's less effective as getting it from your clinic, from a private clinic. A physical exam is not required for vaccinations of healthy person. This is in this context, meaning supplemental immunization activities or your mass immunization campaigns are no less inferior to that of the vaccines being received in private clinic just because it's given to the rest of the population in a manner where a physical examination is not mandatory. Okay. Serologies of limited utility. When in doubt, example, varicella or MMR, it is cheaper to immunize than to ask for that person to have her titers done. First, you're not very sure if that person will come back. And now you lose or you miss that opportunity of immunizing the child or the adult of that vaccine. Okay, the following are false contraindications to vaccination. Mild illness, your URTI, your AGE, antibiotic or antiviral therapy, local systemic reactions after previous doses, prematurity is not a contraindication, pregnant or immunosuppressed household contacts, unimmunized household, breastfeeding, seizures, syncope, or history of SIDS in a family, allergy to penicillin, allergy shots for those who are being desensitized, malnutrition, stable neurologic conditions, brachial neuritis, autoimmune disease, having had the disease, lack of PE in a well-appearing individual, convalescent phase, exposure to an infectious disease, simultaneous PPD test. So if you're supposed to give the PPD today, on the day you're also supposed to give the vaccine, go ahead. A positive PPD test or fainting after a previous dose. So syncope, especially in adolescents. Okay, the last few slides, after I went through all the general recommendations, are the things that I really separated because I really would want everybody to remember at the end of this lecture. First is, remember to vaccinate adults and adolescents. I'm a pediatrician, and right now our thinking has to be moved to include adults. When we mean adults, the elderly, the healthcare workers, the pregnant women, and adolescents. And these are the different vaccines that they need. Second, be on time. Stay on schedule. We know that we told you earlier, you may not count the dose, you can count the dose if it's given at the maximum time. But you know, vaccines are given according to a schedule that has been created based on extensive study and analysis. And basically, if you make up your own schedule, you're choosing to give shots at time intervals and combinations that have not been studied. So down to the colors of the table, everybody tried to fight on should it be red or yellow. So it's easy. And really we wish that when you look at the table, everybody would see it at a glance and understand. It would give them a glimpse of how they would be immunizing their children. But beyond the table, there are footnotes. And therefore, stop and read. Don't forget the footnotes of your schedule. Always read, always heed. And with that, I think that's my last slide. I'm on time. We hope that we help children grow up healthy, by giving them immunizations, protection for everyone, vaccination for life. Thank you.
To present her certificate of appreciation, may we call on stage our speaker together with Dr. May Montellano and Dr. Sen Nakaba.
Thank you for being with us the whole morning and listening to all the lectures. At this point, may we call on all our first three speakers, including our keynote speaker, to stay in front for the open forum. And for those who are brave enough to ask questions, there are two microphones at the sides, middle of the room on both sides, so you can ask your questions directly. For those who are a little bit shy, our organizing committee will go around and get your written questions.
Thank you very much, Chris. I practice occupational and industrial medicine, and we advocate the vaccination for employees. My question is this. Several years ago, I think 10 or 15 years ago, there was a suspicion of vaccines given to women, pregnant women, to be laced with abortifacients. I don't know how true this was, and if it was a rumor, where was the rumor coming from?
Okay, that was a concern along several years ago. I was also invited by the Bishops' Conference of the Philippines to answer that concern. The tetanus vaccine that we do have do not contain any abortifacient. Okay? There was this study ongoing then in India. It was a simultaneous thing to utilize the tetanus vaccine not as an abortifacient but something on reproduction. Okay? But it was not in the vaccine itself. So it was just a sister, a religious, a nun, who was the one who said that the tetanus bacilli, that the tetanus vaccine contained abortifacient. But it was all looked into, and there was no abortifacient at all. And this came about again. This was raised again because the DOH is now going to go into a pilot project to give TB to our adolescents. And again, this concern is now again surfacing. And well, I've already given also the websites where they can look into regarding this matter. Definitely, tetanus vaccine is not an abortifacient. Does not contain any,
Like HCG, they initially thought it was HCG based on the anti-tetanus vaccine. But if indeed you've checked and there's no fear, then we can assure our patients that tetanus vaccines don't have HCGs or anything that has something to do with pregnancy, because by chance their target was pregnant women. So there was a suspicion that it could have been laced. But if you've investigated and it was verified that indeed were no abortifacients, then we can assure our patients. Because up to now, there are fears, and this affects the delivery of vaccines to our patients. Thank you.
Yeah. May I just suggest, because the Philippines is still one of only 3 or 4 countries now in Asia that still has neonatal tetanus. In fact, just recently, a few days ago, China declared no more neonatal tetanus. So it's only Philippines and I think Papua New Guinea that still has neonatal tetanus, and that is a shame for our country, who is now a leader in immunization. So may I suggest to the Department of Health that if indeed there's a political motivation for the abortifacient thing about tetanus, then we can give it as soon as the child or high school graduates. You may not have to give it during pregnancy. You can give it between 14 to 44, which is actually the recommended age for the tetanus toxoid. It is a political thing about this abortifacient that started long ago when Dr. Flavier was a candidate for the senatorship. And this has been recognized by WHO. WHO has indeed declared it is not an abortifacient. The continuing, sustaining adverse effect attributed to the tetanus toxoid, I hope will go out very, very fast, because we still have to save those children from neonatal tetanus. So please, for all of you, be an advocate, try to convince our policymakers, our politicians, that it is not an abortifacient, and we can all be good if we use it. Even for pregnant women, it is
Thank
safe.
you.
Since the monovalent rotavirus is now available in some health centers, they give it simultaneously with the oral polio virus. Is this acceptable, or do we have to wait for at least 15 minutes? Or
You can give. It's the technique, but you should not stop. You should count the vaccine as valid, even if there is no need to give another dose when the child validates.
And my second question is about rabies. Is there any update on that? I mean, if a child comes to us who has already has been bitten by a dog, do we still wait? Since we have the pre-exposure vaccination, what I do is if a child has already that exposure, I give the complete 5 dose.
I will refer you to Dr. Rakyambao, who's right over
Because
there.
in some, they still some surgeons.
Dr. Kiambao, Beijing. Dr. Beatrice Kiambao is the rabies queen.
Okay, Dr. Rakyamba. My question is, for me, if a child has been bitten by a dog, I already give the complete 5 doses. But some surgeon, they still, there's they observe the patient and the dog 10 days. Thank you.
To answer that we don't observe anymore. Observation is, I think, a thing of the past. But perhaps you're talking about a new WHO that came out in 2011, February of 2011, that talks about victims of vaccinated dogs. Because there's a separate administrative order which you can download from the WHO website that says that if your dog is vaccinated for the past 12 months and has received at least 2 doses of the vaccine, and that child or the person that was bitten has a category 2 exposure, which means these are the minor exposures that do not bleed, and the dog has not bitten anybody else in the past 24 hours, then you are allowed to observe, provided the dog is vaccinated, has had 2 doses of rabies vaccine, and within the last 12 months is healthy and observable for 14 days, is in the care of a vet, and the bite is not on the head and neck area. So it's a little complicated. You can download the full AO from the UH website so you can study. Perhaps that's what you're talking about. But the old practice of any bite below the waist, you just observe, that's no longer followed. We give vaccination for all exposures, category 2 or 3. Does that answer? I want to ask a question, and this also pertains to rabies vaccine. When Dr. Tabor said that you cannot give a fraction of a vaccine, I was a little concerned because we do give the rabies vaccine into Germany at a fraction of a dose. So is that an exception?
What we're trying to say is for those that are recommended. and giving a fraction, so meaning a fraction of that intradermal,
Okay.
yeah, that becomes not. But because this is already part of the in-label, of the recommendation of DOH, that is the recommended dose.
Just, I hope it clears up that, because if you said there's no exception, I think you should put there is an exception because it's a fraction of a dose.
But that is the recommendation, so that is the dose. It's not a fraction.
Because the usual dose is the IM. Baka that's what people
That's
will
what you
understand.
yeah. But Dr. Raparan, di ba, it's a standard already for the Philippines. So that is the dose. So it's not a fraction. It's an intradermal dose.
I don't think you can give a fraction of the IM.
Yeah, exactly.
It's so little.
Yeah, but thank you for clarifying that.
The recommendation is actually a fraction. That's what you mean. So you cannot fraction a fraction.
It is already a recommendation for intradermal dose. So for intradermal dose, you use 0.1, and that's standard. So that is not a fraction.
This is regarding the rotavirus vaccine. Is it all right to transfer the rotavirus vaccine to the nipple so that the baby could suck it? Would that be all right for the brandies and say Rotatec?
That is not allowed because you're going to have contamination and likelihood of, the vaccine itself, the dose may turn out to be suboptimal or lesser than what is supposed to be you are going to give because you can have spillage. The baby, it's only just drop. It's a technique. It's how you just give the vaccine. When you give the vaccine, don't give it directly, meaning to say, open the mouth and in the middle of the tongue you put it. It's usually on the side. It's usually on the side. And then you always, in children, kasi adults like us giving that vaccine, infants will copy you or simulate what you are doing. So when you give it, you just say, and the infant will look at you while looking at you. He also will swallow. So that's a technique that you have to do. It has to be given on the side, to prevent. And don't give it at one time. Let the child swallow. Because there are times that there are people who will give the vaccine 1 drop. It is not 1 drop, it's 1 ml or 2 ml. The child is really going to spit it out, or the infant is really going to spit it out.
In the middle, at the side. It's very easy actually. At the side of the mouth and do it gradually. Don't squirt it all out like what Secretary Ona did some time ago.
I have another question for Dr. Atabora. With regards to the false contraindications of giving vaccines, on that the oral live vaccines are not supposed to be given to children who stays or live with a person who is immunocompromised or like one who is receiving anti-cancer drugs. Isn't that a contraindication for giving oral vaccines, live oral vaccines, not anymore?
It's not, while the condition exists, but it is not, I don't have my slides, but it is not a contraindication. It is, while the person, it is a temporary, but in fact, if you weigh the risk and you feel that the patient doesn't come back, you just have to give the live vaccine. It is not a contraindication. Like, for example, there's somebody who is on cancer immunotherapy, who has chemotherapy, and then the child comes, you have to give rotavirus vaccine, you have to give oral polio vaccine. Yeah, you give the oral polio vaccine.
Thank you.
So I have plenty of written questions here, starting with Dr. Suzette Lazo. The question is, you mentioned that PMS requires 3 years, but FDA requires PMS for the registration of flu vaccine, even if the shelf life of flu vaccine is only 12 months. So the question is it really necessary to perform PMS for flu vaccine?
Thank you for catching that. That's exactly the point. We need to revise and institute perhaps more stricter, on a stricter sense, the risk assessments that should be the responsibility of the company. But of course, we should also maintain the current passive surveillance system that we have. Because short of having what other countries have, like the prescription event monitoring, when they really try to monitor all those who, that's very difficult for us. So FDA is right now looking at this, trying to improve the regulation that's being imposed on flu vaccines. It's also a problem with other regulatory countries, and so we are also looking at the model that's being followed by other countries abroad on the regulation of influenza vaccines. Thank you.
The question, is it recommended that 2 health workers will administer the vaccine, one to aspirate, one to inject? No. The answer is no. One healthcare worker can do it. Next, we have clients who come to the health center to continue the doses of their child immunization. The mother started her infant's immunization in one of the pediatricians availing the 5-in-1 vaccine. Is it beneficial for the infant to avail the vaccine at the health center? So if you mean continuing the 5-in-1 series, yes, they can avail that of the health center. What we were saying, there is a preference, is the DTaP dose. We're talking now of the DPT, Hep B, because you know that the health center recently, DOH recently has gone into full nationwide implementation of our HIB. So yes, they can avail if at the health center, because if they have to complete their vaccine and they cannot afford completing it with their private MDs, there is no reason not to complete it at the health center. The interchangeability we were saying is acceptable, but there is just a preference for the following, which is your rotavirus, your cervical or your HPV vaccine, your pneumococcal conjugate vaccine, and your DTaP. But the 5-in-1, they can avail of it from the health center. You should congratulate me. I'm reading without my glasses. Can we use the ordinary thermometer to monitor the temperature of the vaccine ref? What thermometer? The room thermometer that we have might not be able to monitor it because it is really meant for the room temperature, and it will not be able also to monitor sub-zero or drops, because if you look at that thermometer, it's just up to 0 or even maybe a little higher than that. There are specific thermometers. You can buy them in Bambang, or maybe there are industrial areas. No, sorry, T. Mapua, T. Alonso, that area that sells industrial thermometers. You can purchase through your local health service vaccine managers, because I think they're providing, and most of the thermometers now are digital.
I think this question is for Dr. May, or whoever wants to answer. The first question is on meningo vaccine. Is there a need for a second dose or a booster? And when? Especially in cases or if there is a presence of meningo cases.
Currently, we have 2 meningococcal vaccines, okay? We do have the Polisac and the conjugate. Okay, for the Polisac vaccine, we are not recommending it for children under 2 years of age, okay? So, generally it's given for 2 years and above. It's not routinely recommended because we have, yeah, I know, in Baguio, because of the outbreaks that you had before, it was a recommended vaccine. So it was given. And the vaccine that you utilized then was a Polisac vaccine. Okay? However, for 2 years already now, we've had the conjugate. No, here in the Philippines, but outside of the country, the conjugate vaccine of meningococcal has been available in the United States. And then it was later introduced here in our country. Okay, I've said in my lecture, for polysaccharide vaccine, they are non-immunogenic to 2 years and below. Okay. We advise that the conjugate vaccine be the one used because it will induce an immune memory. And so therefore, upon exposure to another infection or with the organism, it will mount an anamnestic response. Okay? So it has a boosting effect. With the polysaccharide, none. With polysaccharide, if you give it for repeated doses, you are not going to get the immune response that you want, because it will always be a primary immune response. And it has been shown that eventually that primary immune response will also decline. You will have hyper-responsiveness to the vaccine. So kaya that's why we prefer you give the conjugate than the Polisac. Okay? Now, the vaccine is supposed to be given only once. Okay? But if you are immunocompromised, you start off with 2 doses. And then after that, depending on the age, when you got the vaccine, the age like 3 years or 5 years old, and then 7, then the interval will depend on that. Okay? So you can give the meningococcal vaccine to prevent. Okay? Primary prevention, if you really want to be prevented from it, you can request, even though if it is not, there is no routine recommendation. So a vaccine is available to prevent for all vaccines. Even if it's not routinely recommended, you want to be protected, you can demand for it and you can have it. But, you know, there is, currently, we do not have any routine recommendation for its use. That's why the vaccine can be used upon demand by people, and then also when outbreaks occur, or when there are risk factors to the infection, then you can give it.
Tomorrow, I think Dr. Aguirre will discuss the recommendations on when to give the number of doses and the minimum age. I think it's tomorrow morning. For meningococcal, everything will be there discussed in your lecture, the 2012 recommendations.
Okay, so this is for Dr. Tabora again. Can you recommend any tips on the proper administration of the HPV vaccine without the very painful or uncomfortable experience our patients had with the first injections, like any other injection site or manner of administration? Because most of the patients now who receive it complains of pain.
For all the vaccines, as I said, that's why the British now call it a jab. The best way to do it is give it quick and fast and withdraw it fast. And in my practice, really it's true. Sometimes, tapos na pala, they didn't realize it. But you have to explain to them that there really are vaccines, like your tetanus toxoid, that really, they're heavy. And it takes days for the pain to wear off. And maybe to warn them and to say ahead of time that you'll feel uncomfortable in the next 2 or 3 days would lessen because they anticipate it. More of the problem for HPV that they have seen abroad is syncope associated with giving it to teenagers. And that is as a consequence, because they leave the clinic earlier than 15 minutes from the time the vaccine is given, and it happens when they're out of the clinic walking, the adverse event that follows is not that of the vaccine of syncope itself, but they have bruises or scratches kasi di ba natutumba. So following your HPV vaccine, it's really advised to, and this is for all vaccines, to let them stay in your clinic 15 to 30 minutes and observe them. And for some teenagers, if you've had a syncope in the previous dose, it is not a contraindication, but you might as well ask them to lie down and then rest following the immunization, and then stand up or sit down while you give it, and then they leave after 30 minutes from your clinic.
Actually, we only have about 5 minutes to wrap up this open forum, but please be assured that there will be more sessions on vaccines. Tomorrow, the vaccine concerns for children, for adults. You will have a chance during the panel discussion to also ask your questions, write your questions, but this is not actually the end, because we do have a lot more questions here, but I guess, you know, we have to keep on time. So I'd like to address this question that's been given earlier. How do you convince a mother to have her child vaccinated when she is worried about the possible autism complication? You know, for me, personally, I would say that this autism thing complicating MMR is now a gun issue. Rubbish, thrown away, down to the garbage. It's already a myth. People who are still trying to sustain this is not doing it for the purpose of science. The person who started it all is now under hot waters, is in disrepute, if I may say so. And somebody says from UNICEF that to be in disrepute is like to be a prostitute, because in fact, disrepute. Somebody said that to me. If you are called in disrepute, it's like being a prostitute. But indeed, the person who actually, or that paper that first published this about 18 years ago is now thrown out, no longer in existence. It's like a ghost coming back every so often to haunt us, but it should not be. It's a thing of the past. And somebody who still, as I said, manages to say this is probably living in a world of make-believe. So it's like, for me, it's like the abortifacient thing, as Therese here said. You can say that even this abortifacient cause for tetanus is also a myth that should be thrown away.
May I add something to that? Seth and I were saying, you should think first before you spread something, because the person who did this has already been debarred, and his paper has been retracted by Lancet itself, by Lancet. So because it was published in Lancet, that paper, and Lancet himself retracted the paper. Okay, so that means to say, it is not, there's no truth to it, and there has also been studies that has been done to compare the incidence of autism in the general population and comparing it with the children who received the MMR vaccine as to what is also the incidence in that group. So there's really no difference, so therefore there is no safety concern. And the other thing which I would like to add, which I failed to mention, meningococcal vaccine is a routine for all who wants to go on a Hajj. That is a requirement by the Saudi government. You will not be allowed to enter and attend the Hajj unless you receive a vaccine of meningococcal vaccine before you go. That's the main recommendation. And there is a certificate which you will have to bring along with you when you go to Saudi.
Okay, so maybe I'm going to ask the last question. This is for Dr. Suzette. In reference to oral vaccines, will there be a move for the EPI to shift to IPV, since considering the WHO recommendation for IPV?
Well, you know, the WHO is our technical advisor. I really cannot answer it right now. It's in the hands now of the new director, the very able Dr. Kenneth Hartigan Go. So most likely, it will be in that direction.
Thank you. Some of the unanswered questions we will include them tomorrow for the panel to answer. So I think this wraps up the morning session. We will have now our working lunch. We are requested to get our food first, settle down before the next speaker will start. So thank you.
He moved to the United States and completed his residency at the University of Texas, Houston. He obtained his Master of Public Health degree at the University of Texas School of Public Health and completed a fellowship in adult infectious diseases at Baylor College of Medicine. He has held several academic positions during this time in the Department of Medicine at Baylor College. He joined Sanofi Pasteur in December 2006 in Swiftwater, Pennsylvania, USA, coming from GlaxoSmithKline Biologicals, where he had been leading the rotavirus vaccine clinical development program. Prior to his appointment at GSK, he held the position of Director, Regulatory Affairs with MSD Europe. He is currently based in Singapore as Associate Vice President and Regional Head of Clinical Research and Development and Medical Affairs of Sanofi Pasteur Asia, to speak on one of the hottest topics in vaccinology today, on the clinical development of the dengue vaccine. Please welcome Dr. Alan Bukinugi.
So, good afternoon, everybody. Pleasure to be here with you. You know, we took a tour overnight to get here today, and I've been in Manila, of course, so many times, and wondering why people love so much big cars. Of course, this is a practical thing. I was thinking maybe, you know, people care for big families and want to move around the city with extended family. Or maybe I was told that ladies like shopping a lot, so you need a big car to put all your things in the car. Perhaps because of the rain, it's useful to have an SUV or a car that sits a little bit higher, you know, that you don't get wet. But coming to Baguio overnight, I was told that this is a favorite spot for people to come from Manila in summertime. And so the road was a little rough, and I think this is part of the reasons why you love big, high cars and SUVs. So I'll talk to you a little bit about the dengue vaccine development. And we are certainly in Sanofi not the only company working on that. There are extensive efforts ongoing. What I will be doing is give you a little bit of background on the virus, the transmission, the disease, the epidemiology, although it's well acknowledged that some amongst you are really experts in the field, so I'm sorry if this is a bit repetitive, but we have a mixed audience today, and I thought it was good to recap. And I'll then talk about the Sanofi Pasteur candidate dengue vaccine, with the results of the proof of concept, the results that became available and have been published in the Lancet not too long ago, with some conclusions. Meanwhile, I know you're enjoying your lunch. There will be time for some questions at the end if we wrap this up timely. And I need to multitask, but I'm not sure if this is working. Okay, so next slide, please. Okay, and again, next. So dengue is a global problem. It is a mosquito-borne disease. It's a flavivirus in terms of classification. There are 4 different dengue serotypes, adding to the complexity. And looking at the map, the global map, you can see, of course, that the 4 serotypes are widely dispersed in the tropical and subtropical regions. Those are mainly in the regions of Southeast Asia, including also India, and also the Caribbean and Latin America. There's probably also dengue in Africa, and the question about how important dengue is in Africa is still not completely clear. The dengue virus is occasionally isolated from mosquitoes, and by time also one finds travelers getting sick with the disease. But it's not commonly identified in Africans. I'm sorry. It is thought that this is probably the original home of the dengue virus, and that the dengue virus has spread out of Africa to the other regions, although this is not sure. And it could well be that African populations have been subselected because of the severity of the disease, and that as a result today, the genetic makeup now is such that local populations are less vulnerable to the clinical symptoms of the disease. There's been a lot of studies done in the Caribbean, specifically Cuba, on that, to look at ethnicity and dengue severity that yielded very interesting results that point towards that direction. So there is a neglected tropical disease work group by WHO, and they have put their focus on dengue for quite a while, and they have set several milestones actually. Working? One of the things was that they wanted to reduce dengue mortality by 50% by 2020, and there's good work in progress there. Essentially, it's about good medical care and timely medical care, so this is more an issue for remote people with limited access to health care, and also proper management. There is a goal to reduce dengue morbidity, that's already tougher of course, by at least 25% by 2020, and to ascertain the true burden of disease by 2015. I don't think this is working yet. Georgie? Next slide. Okay. So here you see a picture of the virus. As mentioned before, it is a flavivirus and is related to the yellow fever virus, Japanese encephalitis, tick-borne encephalitis, and West Nile. And those are very closely related. They move on a different spectrum between hepatotropic, encephalotropic, or generalized diseases, but they're actually a closely knit family. In the flavivirus family, you have additional viruses, and a formidable pathogen is hepatitis C. However, hep C is significantly different and would not fit in this structure here. It is a RNA virus, and you can see the cartoon here about how it's made up with the different parts. The most important parts are what is on the surface of the virus, the epitopes, which consist of envelope, more the yellow part and a bit of the others, and the premembrane parts. The premembrane parts allow facilitated entry into the cell. And as mentioned, there are 4 different serotypes, then 1, 2, 3, and 4. The vector, the most effective vector is Aedes aegypti, which is best spread in tropical and subtropical regions. There are other vectors that can transmit the disease, but they're not as effective. For instance, Aedes albopictus, which is more common in temperate regions. However, if over time, for any reason, there would be an adaptation and these mosquitoes would be better capable and more effective in transmitting the disease, then dengue would definitely spread rapidly in regions of milder climate as well, as Europe, US, Canada, and so forth. Mosquitoes, of course, need breeding places. They need stagnant water. They are day-biting mosquitoes, so this is not like malaria. This is a day-biter. There's an increase of the mosquitoes during the rainy season. So rainy season is typically associated with a peak of the disease. There is dengue viral vertical transmission described, so from mother to child, that has occurred. For the mosquito, once the mosquito is infected, she keeps it for life, but her lifespan is not reduced. And I say her because it's the female mosquitoes, as we know. How does the transmission occur? Well, you need to have at least one human who is viremic, who has the disease. It is an enzootic disease, and it's also surviving in animals, in certain monkeys. but the source really typically is humans. If you have a person who got infected and has viremia, you could have a naive mosquito feeding on that person. It takes about a week for the cycle in the mosquito to mature so that the mosquito becomes infectious. And then the mosquito needs to feed on another person who was not infected to inject that person with the virus, and the new cycle will start.